Welcome everyone to this week's jam session. This is really an amazing sort of moment that we're a year and a week away from July 16th of 2022. But if you thought that the unprecedented wave of momentum, the tsunami as we've described it, could not go higher, then I look forward to this discussion today. And Karen, if we can go to the next slide. Last week at the very end of the meeting, we introduced a new segment that we're calling Margie's Crisis Meme. Margie, are you on the line? Can you join in?
Yep, I'm here.
So Margie, your first crisis meme from last week, do you want to just set this up for us?
Well, yeah, I mean, there's just so much momentum coming from all different directions that I was doing a talk, I forget who for, but I was trying to illustrate it. And I was like, well, I love memes. So, I mean, because you've got momentum from all of 988, you've got all this funding coming down, and then you've got all the social justice movements around, getting the police out of the business of being the default first responders. And so it's just coming from everywhere. It's like, it's like all the things are aligned, the stars are aligned.
Yeah, and let's go to this week's Margie's Crisis Meme. And Margie, thanks for taking this one on. Tell us quickly about this one.
Well, this one I was trying to illustrate the whole why crisis centers have to get the police in and out as quick as possible and as easy as possible, because you don't want to wait for hours at the ER. Even if you train police to bring people to treatment, they're busy. And if you make it too hard for them to do the right thing, then, you'll disincentivize them. We were told it takes 20 minutes to drop somebody off at the jail. So we get our officers out in 10 minutes.
Wonderful. And Margie, where can people follow you? These memes are on your Instagram account, or where do you put them?
Where should I put them? I will put them on my Instagram. And they're on my Facebook for sure.
Well, we'll add some new friends, hopefully your Facebook account, and we'll share that Instagram information. So Margie, this call comes up every week, so the pressure's on.
Okay, I have some in waiting.
Awesome.
And that's my true calling as a meme lord.
Thank you, Margie. And thanks for your continued leadership. Dr. Chris Carson on Margie's team presented a couple of weeks ago, and it was really this Drake meme was, I don't know if Dr. Carson and Drake are connected, but here we go. Kara, let's go to the next slide. So if you're keeping score at home, back in November, Richard shared with us that T-Mobile had turned on 988. And what I presented at that time, I did a quick search for market share, and T-Mobile at that time was 15 or 16% of the market is what I found when I did my two quick Google search. So at that time, that would have yielded about 15% of cell phones would reach the Lifeline if you dialed 988, and 85% wouldn't have. There were a couple of other extraordinarily small companies that turned it on, but T-Mobile was the big one. So Karen, next slide, the question, and I'd encourage you to put into the text or chat, SAMHSA and NASBID leadership, so don't answer this quite yet. But what percentage of cell phones reach the Lifeline by calling 988 today? So I'd encourage all of you to drop your best guess. Is it 15%? Choice A, 35, 55, 75, or 95. Now, obviously, we're going to be near 100 on July 16th of 2022. That's the expectation from Congress, including landlines. But for right now, where are we at with cell phones? And I'll give you a hint here. I didn't look closely enough that T-Mobile was acquiring Sprint. Sprint's a larger market player. So this 15% was not accurate when I shared it. It was higher than that. So we've got a number of people guessing here. I'm going to let that sit just for a minute. Next slide, Karen. So last week in a discussion with SAMHSA and NASBID leadership, we saw this press release from AT&T. AT&T helps combat the mental health crisis in America. When will 988 be ready? 99% of AT&T's wireless customers can dial 988 right now. Now, I saw this press release and I said, no, that can't be. So I picked up my cell phone. I have an iPhone on AT&T and I dialed 988 and I got the National Suicide Prevention Lifeline. So I brought this up with SAMHSA leadership in Nashville in our steering committee meeting. And next slide, Karen. Dr. McKeon shared that it's not just AT&T. So I don't know who went first. I mean, T-Mobile and Sprint clearly went first, but I don't know who went first most recently, but they all turned them on. They all went on. They're all on. So the answer right now, and we'll get an update from SAMHSA here in a moment, but as of this moment, 95% of cell phones in the United States, if you dial 988, will go through to the Lifeline. I guess there's a few Cricket, prepaid, some things that don't go through. So let's just reflect on that just for a quick minute. The slide at the very beginning was us stretching at the start line. I think we're stretching and we realized the gun went off and there's some people running down the racetrack now. They're moving along. What does that mean that 95% of cell phones now can reach 988? Well, the landlines don't yet have that functionality. So I did just a little bit of quick searching. In 2003, 95% of homes had a landline. By 2018, less than 40%, and the overwhelming majority of those individuals had a cell. And in that quick search, I found this really cool article in the New York Times at the beginning of the pandemic from both AT&T and Verizon talking about a 35% increase in old school, old fashioned voice calls. That the quote I pulled out of that article here, voice is the new killer app. It's been a real surprise. So we've seen a massive number, and not just in middle age and older individuals. They have in the article teenagers who or young adults who call their parents once a week or once a month, going to once a day, as those desire for connection have blossomed during this challenging lockdown. So really phenomenal sort of developments as we thought we had a year and a week, and in some senses we do. Promotion will have to follow in order for volume to hit these numbers, but the foundation has been laid. Next slide, Karen. And Arush, I see your hand up. We'll get to you in just a moment. Now, obviously, promotion is what's going to drive these numbers. Last night, I was on Instagram, Margie, and saw this individual I track in the Midwest who is going back to roller derby. After the pandemic, they haven't done a single roller derby in 18 months, and they were having their first practice. And I just happened to catch a glimpse of her helmet in the video, and the video was about roller derby. It didn't have anything to do with 988, but I noticed, I was like, wait a second, that's 988 on her helmet. So we're off and running. Rusha, you had your hand up.
Thanks, David. I was wondering if it would be possible to get a stat on how many of these carriers are treating it as an emergency number. And what I mean by that is, when I try to call 911 on my phone, I don't have to unlock my phone or do anything with it. It's right. Treated as an emergency number, but how many carriers are treating 988 as an emergency number yet? Yeah, I know.
So let's look to Richard Rusha in his update, because he'll speak to SAMHSA's efforts around the press release that the Association of Telecom wants to put out, and speak to that question in particular as we move forward. And this is exactly where we'll be going next. Karen, next slide. Just for a moment to our states. We did add a blue state. We do have Medicaid leadership joining these calls from California, which I didn't have. I mean, the person was on our list, but I didn't realize they were from Medicaid. So thanks for those of you who pointed that out. And we were on a call with some crisis leadership in Washington State, and they were referencing Representative Lauren Davis. If you know Lauren, Lauren had challenged them at one of their crisis consortiums here. It's been well over a year ago. To bring two new individuals, not family members or friends, but two people out there in the community to their crisis consortium. So help us grow this learning community. We're obviously off and running. If all of you invited two individuals to join us, then we could quickly grow our collective impact even more. But we are tracking specifically where we bring Medicaid partners to the table. So we have Office of Behavioral Health Leadership from all 50 states. Please help us connect with our Medicaid leaders. And if you're a national organization that's not already listed, let us know, and we'll put you on our list. Next slide. Again, these videos and the tools, all the tools. So John Franklin Sierra shared from LA County a terrific dispatch protocol and a future state flow diagram for the alternative crisis response system that Dr. John Sharon and that team is building out. All of that is now available on the Crisis Talk website. And we'll continue to share the videos of these meetings as well. Next slide, Karen. Stephanie Hepburn, a really terrific article about Oklahoma's efforts to use technology. Give us a read on this week's edition.
Stephanie wasn't able to join this week, but we do have Josh Tatwell with us.
Josh, great. Thank you, Josh. So you were the interviewee. You're a CCBHC. Tell us about this interview you did with Stephanie, Josh. Thanks for joining us.
Yeah, thank you very much. David, I wanted to say that you may be the only person that I've ever met that moves at the pace that my brain likes. This is a lot of media, lots of entertainment here. So I appreciate that. I had a wonderful opportunity to do an interview, talk about some of the stuff we're doing in Oklahoma, specifically northeastern and north central Oklahoma, some very rural parts of the state with our crisis response. And I thought that she captured the spirit of everything that we're trying to accomplish. So when Margie was speaking earlier about this idea of getting law enforcement officers the opportunity to kind of do what their job is, right, is to provide public safety, and us be doing what our job is, which is providing the mental health services and the crisis services. That's what we did starting about 5 years ago. We decided that in order to make that happen, we started putting mobile tablets in every one of the law enforcement vehicles. So that's sheriff, police, campus security. We're working on tribal marshals at this point to be able to give them instant 24-hour access to face-to-face consultation and assessment services in the field. So at this point, we have about, I think it's over 800, we call them mental health machines in the cruisers. And so anytime they come across someone that's experiencing a potential mental health crisis, they pull that up. It's in single app mode. So when that machine's live, they have the choice to hit two buttons, and one of them is a crisis button, and that connects them live 24 hours a day with licensed mental health professionals to help make that assessment.
Josh, that's really a terrific interface. And we've been talking a lot about 911 and 988 coordination, as well as this interface with law enforcement. What have you seen in terms of utilization? How is that growing?
Oh, so it's absolutely, it's utilized thousands of times a week right now. So obviously, anytime that we introduce a new innovative technology, it has to work is the first thing. So when we went live with this, we ensured that there was always someone live to answer that phone with minimal rings, because the first time that we determine that it's not reliable, that's when the news spreads and law enforcement officers would not want to adopt this new technology in their vehicle. So that was the first key, is the reliable nature of this. So the other thing is that we have 3 units operating 24 hours a day that are a variety of levels of care. So we added 2 new levels of care through this transition. We worked closely with the Oklahoma Department of Mental Health and Substance Abuse Services to make sure that there was a level of care that met the need for, least restrictive environment of individuals needing crisis services. Because before in Oklahoma, really there was 2 levels of care. You had outpatient level of care, and you had residential treatment level of care, where people's civil liberties were being taken away. And we know that there's multiple crisis needs in between there that could be met. So we opened a couple new levels of care, but the significance is that we have people on staff that are providing the actual treatment, answering those calls coming in 24 hours a day, making the determination where law enforcement officers can get on the road and en route to the nearest location for the least restrictive level of care. And Margie talked about a 10-minute turnaround. We're talking 5 minutes, right?
Yeah,
they're in
terrific,
and they're out.
Josh, there is a lot of questions in the chat. So I think we'd like to talk to you about doing a featured presentation on this in a future meeting.
Yeah, absolutely.
But for now, because there are questions about the protocols, the utilization, the capitalization, I'm just tracking all of this coming through quickly. So
Yes.
Let's get you on the schedule to come in for a 10, 15-minute presentation if you're open to that. But for now, encourage everyone to read the article, the interview with Stephanie on Crisis Talk. And Josh, thanks for this for this innovation. We'll share your contact information. I can tell there's a lot of interest.
Okay, sounds good. Thanks a lot.
Thanks so much, Josh. Next slide, Karen. Debbie Atkins, are you with us today?
I am.
So Debbie, last week you and I were talking before the call began, and you were just reflecting. We track the legislation every week. Georgia has not yet introduced legislation, but you made this statement that I thought was really important. We've got one shot to get this right. Talk a little bit about what you were thinking when you said that.
So, if you go in and you're too quick to put legislation out there, there is the risk. You have to go back and change legislation. So for us, we have looked at what's going on across the country. We know our cost. We've been doing this for a while, and we want to make sure that when we put it forth, that we have the buy-in from the governor, the buy-in from the legislature, and that it is something that we feel, one, that we can pass, but two, that it'll fund what we really need it to fund. Georgia's not an expansion state. We're limited in how we fund things. Right now, it is some admin dollars and pretty much legislative dollars, and they have been incredibly supportive of us. But looking at what we've got to move forward to accommodate 988, there's no way the state coffers can pay for that. So we really want to get it right. We want to make sure that we're comprehensive in our legislation. So we've kind of taken a shot at, hey, let's do it right. Let's make sure we get it right, and we don't have to come back and clean it up later. Yeah. And Debbie, the other thing you were mentioning is just the forecasting, right? We're never going to have a total clear picture until it happens, but getting that prediction of incoming volumes and demand correct. So Debbie, great work. Thanks for your continued leadership here. Next slide, Karen. So Dr. Anita Everett, are you with us to have some update from some of the SAMHSA team?
Yes, thank you, David. Yeah, and I want to thank, again, nod to NASHBID, Brian Hepburn at NASHBID and you for hosting this, and also to Brian and NASHBID and Richard from our team, who were some of the founding fathers, so to speak, if we're on a Hamilton roll of this process. So thank you very much for that. Yeah, we've been focusing, our highest priority at the moment is focusing on 988 itself, the calls, texts, and chats. That is, clearly one of our roles as this, 988 becomes available or sort of grows out from the suicide lifeline. We've been sort of working on that initially by supporting and expanding the backup centers that are part of it, just to make sure, in our keeping with the theme of what does a person in crisis need, starting with the person and the needs of the person. We want to do whatever we can to assure that there's responsiveness on the phone as a start place, and then other systems that this community recognizes are important in providing also a person to respond that's an appropriate and trained person, and also a place to go that's a safe place to go. So that is sort of the big picture of our priority. We're also working on the president's budget has an increase in the block grant, which is accompanied by a 5% set aside for crisis services, and we're working through our slow federal ways on language and notice out to the states when that comes up, depending on what actually passes in the final budget. We'll give the states, a variety of resources that they can use also for crisis development. Those are our main priorities. I want to turn to the rest of my team and see if there are any updates from Dr. Palmieri, who's our lead on this, and then also Richard, I think, has some updates as well.
Terrific. And Dr. Everett, we also want to begin to, maybe not an every week thing, but incorporate an update, a specific update on that 5% set aside work. And you want to introduce your team member who leads that?
Sure. I don't know if he's here today. It's Thiessen. Thiessen is our form. Oh, yes, Thiessen's here. Yeah.
Yes,
Thiessen?
I am here.
Yeah.
Definitely. And I'm very happy to provide some updates on the 5% set aside, how states are using it.
Maybe we can start with that next week, Thiessen. That'd be great.
Of course. Yeah, definitely. I can share. How do you want it to do that, David? Do you want some general updates, or I just want to make sure, we have 50 states, 6 territories, and 3 associated states that we fund,
Yeah, so let's talk about how best to do that as we go along, and we'll just incorporate it as a regular routine update.
Okay, great.
John, John, the SAMHSA team will work it out under John's direction. Yeah. That's good. John, did you want to say anything?
I'm going to yield my time to Richard, and just to say that we, as Dr. Everett said, are very focused in on the federal planning role with respect to the 988 implementation, having lots of conversations, mostly with federal partners and external stakeholders to really kind of align our messaging and communications. And I think Richard's going to provide a little bit more detail based upon your earlier comments, David, with respect to communications and messaging.
Terrific, John. And Dr. McKeon, you were telling me about a press release that the Association of Telecom wanted to send out. What's the status of that?
Yeah, well, so as you indicated in your quiz earlier, the answer to the question about what percentage of cell phones in the United States currently have 988 active, the answer to that is 95%.
Oh, my.
That number comes from CTIA, which is the lobbying/advocacy group that represents the cell phone industry. And they do have a desire to do a press release, kind of with the frame that, that the cell phone providers have made this active a full year before the FCC requirement. But from a messaging standpoint, this presents several challenges. Okay, so on the one hand, the CTIA believes, and they are likely correct, that there are many people, 95% of the cell phones, that have access now, for whom it would be a benefit to know that they have access now. The whole point of a 3-digit number was that it would be easier to remember, more people would utilize, etc. On the other hand, there's also the two other issues around that. One is that the communications around the fact that it is not yet universally available. So, and there could even be confusion within a family. So for example, for me, I'm a Verizon customer. My Verizon cell phone has 988 available. I tried it, it works. My landline, which is also Verizon, does not have 988 available. It doesn't work. I've tried that too. So the messaging about, that, hey, it's great that all these people have access to 988, but a lot of people don't, and that 1-800-273-8255 is universally available, as well as being available for text, as texting to 988 is not yet available, is a more complicated message. In addition, as SAMHSA said originally in our report to the FCC back in 2019 on a 3-digit number, we thought the 3-digit number could have a transformative effect on mental health crisis services, as long as there were adequate resources for the local Lifeline crisis centers to be able to answer all of the calls. We are extremely pleased that the president's budget has a quadrupling of Lifeline from 24 million to 102 million. But of course, the Congress has yet to act on that. We're also, of course, very pleased about the potential for the mental health block grant funding and for the cell phone user, fees as being potential. But that is a process that is evolving over time. So there are complex issues. We are pleased that CTIA has reached out through the FCC to SAMHSA. So we have begun a conversation with them about this somewhat complex messaging, and we'll try to keep people informed about that. Just one other thing in response to a chat. And basically, the question was, is 988 being treated as an emergency number?
Right.
And what that means, at least to the best of my understanding, is that 911 currently has certain kinds of statutory and regulatory protections. So in the event of PSAPs going down, et cetera, there are protections to help it get back online as quickly as possible. SAMHSA has had discussions with the FCC about this and requested additional information from the FCC about this. So we're trying to take a look at what would be potentially required to extend such protections to 988 in terms of change in statute or regulation. So we're still trying to understand that as best we could. But the answer right now is that no, 988 does not enjoy the same kind of protections that 911 has. So that's what I have.
Wow. Well, that's a lot, Richard. So thanks for sharing all that. And while Richard was talking, a number of questions came up about how the 988 routing works, which builds off the current Lifeline routing. Our center's getting information. And look, it's probably worthwhile to have another Lifeline. I see Dr. Draper responding to some of those comments right now. John, let's get another Lifeline update on the pipeline schedule to talk more in depth about some of that. So, wow, a lot, Richard. Let's go to Brian Hepburn from the States. Brian.
Yeah, thank you, David, and thank you for your continued work. And I want to thank Anita and Richard, Thiessen, and John for their support. Also, I want to echo what Debbie said. We have to get it right and then respond to your 95% of cell phones being connected with 988. Just to say that scares the hell out of me. I think it really shows how much work we've got to be doing soon. And I want to thank you for championing this work. Want to thank Josh for his iPads. That was a great idea, and I really enjoyed reading about that. I think it's the use of technology to make this all work, I think, is very important. Want to echo Margie's comments and memes. There's Margie uses a lot of humor, but her content is right on. And I love hearing her talk, and I really like her memes. We continue our calls with the state mental health commissioners. We continue to focus on 988 crisis services post-COVID-19. We're really trying to emphasize strategies going forward, and consistent with that, I've asked Brian Sims, our medical consultant at NASHBID, to say a few words about the equity and trauma-informed approaches that he's presenting on this, working with the state commissioners on a regular basis. Brian?
Yeah, thank you, Brian, and thank you, David, and all for this opportunity. Brian, I will say this to everyone. I love what has been said, because when you have a theme already designed as far as what you want to say, and you hear the themes being given back to you, it shows how correlative the states are in terms of communication. What Brian had mentioned is that I'm the senior medical advisor with NASHBID, but I'm also really a pleasure to be involved in the team's quarterly calls that we have to the various states. We talk to the commissioners on a quarterly basis, and we use the theme from NASHBID that one of the long-term goals has been promoting equity in the delivery of mental and behavioral health care to all individuals served. And that constitutes one of the major topics that I speak on with each state. So I have the pleasure of speaking with the commissioners about their challenges, about initiatives, about requests for updates and information, with the intent of really determining their individual efforts to address inequities and disparities. All states are looking at these as very important endeavors to really attempt to address. Now, all states appear to acknowledge the fact that racial, ethnic, geographic, as well as IT disparities challenge them in terms of how they address equity. However, it's really been exciting to see how they are going about addressing it. Many of the states have shared their various plans to address each of the aforementioned, but a common thread that seems to emerge is the acknowledgement of the critical need for connection in times of crisis for all individuals. And we've been working for years in terms of how this connection is made. It's made through trauma-informed lens, trauma-informed system transformations. But one of the things is going back to what was mentioned earlier in this meeting, was having a universal, simple means to connect. And that connection does not involve internet or Wi-Fi, because when you look at equity issues, many of the marginalized communities don't have these tools available to them. So having a call number that doesn't require a set of instructions or guidelines for usage only tends to increase the number of persons willing and able to access those services. So in that manner, there's a heightened empowerment, there's decreased barriers to access of care, and it improves and equalizes opportunities to receive help when it's needed. So with 988, states see a need and a powerful tool to add to their toolboxes to now help address equity and disparity issues. So what this does is gives all individuals that we serve a crucial starting point to their continuity of care and an access portal that's going to lead to potentially long-term treatment. So I thank you for the time, but I just really want to acknowledge that these connections come from not only the states, but all of the territories that we serve, because they all have unique challenges, but this is one combining component that we see as going forward, a very powerful tool to help address those who are unable to access it.
Oh, wow. Thank you so much, Dr. Sims. And this quote, critical need for connection in times of crisis is, I think, just hits the bullseye. But then this concept of, as Vic Armstrong has referenced, of building a lens to race and equity in on the front end of 988 is so important, and great comments setting the stage for Whitney Bunts today. So thank you, Brian. Thank you to both of you. Next slide, Karen. And Sarah Corcoran, are you with us to give an update on the national level?
Yeah, absolutely. Thanks, David. So today I'm just going to focus quickly on where we are on the FY22 appropriations process on the Hill. So far, we haven't seen much action in the Senate on appropriations for FY22. For the House, today is the markup at the subcommittee level for the Labor HHS approps bill for FY22. We expect this will go pretty quickly. Usually they kind of save the amendments process and proposed edits from both sides to the bill text until the full committee markup. That will be a lot longer. I think today will be pretty quick if history is any guide. They have released the statutory language. It is not the English language translation that we like to see in the committee report language yet. So it is very technical. We do see that the mental health block grant is funded at that $1.72 billion level, and it does include $35 million for the crisis care set aside. This is not a full done deal yet. There are still plenty of time for amendments. Potentially, we've been trying to get that block grant set aside up to 10%. So we will see if we are ultimately successful in that regard. But last week, one more piece adding towards that, the Bustos Fitzpatrick authorizing bill to increase that set aside to 10% was introduced on Thursday. I'm happy to drop a link to the press release and the language. We're going to continue to make that push to see if we can get it to 10% in the final bill, but it seems like a very strong bill, again, in a very technical sense, to really focus on mental health and substance use for FY22 coming from the House Labor Approps Committee.
Oh, Sarah, that's great news. And thanks for sharing that link. You had shared it with me. I had intended to get that 10% set aside bill into the presentation today and didn't make it. So let's keep working that and look forward to updates on that. Thank you, Sarah. Laura Evans, let's go to the next slide on the AFSP tracking of the legislation. Taylor or Natalie, any comments from AFSP today?
I actually have a quick state update. I know we have that coming, but it's very timely because I just got done with the meeting. There will be a bill introduced in Tennessee. I was met with Senator, name keeps escaping me, Heidi Campbell out of Nashville. So they're drafting that now, and they want to have it pre-filed by the fall, and they want to do a public campaign ahead of that to make sure that there's attention. But basically, if the public isn't aware, it's not going to go anywhere no matter how good the bill is. So I can fill in the other groups later, but we discussed some strategies for that. So we will have a bill in Tennessee in the next couple months. Wow,
terrific, Taylor. And let's go to the map slide, Karen, that Taylor is referencing Tennessee. I did not have that information, so that's great. And Laura is not with us today, but she did send me an email, just no changes to the map, but Oregon and New York still passed both chambers, not signed into law yet. Massachusetts hearing set for July 19. That's all that she's seen. Angela Kimball, are you with us? Any updates from your vantage point? So Angela may not be with us today. Let's keep going. We're a little tight on time. So the 5 seconds of the crisis calculator, Paul, we're going to hold you to that 5 seconds today, but I know you're going to just go back. We've got a lot of new members joining us. The community forecasting calculator on the crisisnow.com website. You're going to quickly take us through the core components of that.
Yeah, I think that's right. And I will say that, look, Anita always reminds me of how important it is to have someone to talk to, someone to come to you, a place to go. It's about immediate access to care for those in crisis need. And so what the calculator does is it focuses largely on that mobile response and facility-based response. We know John, Richard, and their team have worked on projecting the call volumes that we'll see coming through 988 already. So if we can get to the next slides, David, is it Karen that has them? We have a little visual of the calculator. Oh, maybe we don't have that.
Well, and that's where we're going, Paul, but just, you know, a lot of this was built off of this idea of diversion. So I put Margie Balfour's great slide in here. Karen, let's go to the next slide. You know, Margie was just looking at their experience around the potential impact of this. And this all plays into the modeling underneath here, Paul.
Yeah, that's absolutely right. And look, the calculator that we're looking at is really a spreadsheet which is posted on NASHBID's www.crisisnow.com website. And in the first tab that you'll see here, if we keep clicking through, Karen, it's going to allow you to project out the number of mobile teams that you need circled there. We go to the next one, the number of 24-hour or less crisis receiving chairs that say yes to everyone that comes in. The next one, it will project the number of short-term beds, often lengths of stay of 3 days, and then acute inpatient for a community. And what it does as we work our way to the next one is it also shows us how much each of those things cost. And remember, it's a spreadsheet, so it's editable. And what we're going to do today is just quickly go over this overview of the structure. It is posted on the website, so you can get in there and play with it. And we'll look at details on how we edit this as we go through the next few weeks. But on the second tab, what it does is it looks at who are the actual funders and what does that look like. So at the top table, you're going to see this is where you project out what your funding mix looks like, whether it's commercial payers, Medicare, Medicaid, expansion population, Medicaid, because the federal match changes. As we get to the next group, we then look at costs affiliated with each of those payers. And then finally, what's important to you all as you're working through your state budgets, and Tom has shown us opportunities to use HCBS enhanced funding to pay for some of these things, you can see what the state spend is on these things. And as an example, if we look at mobile crisis on the next slide, we're going to see a projection somewhere around, if I can see that right, about $13 million that we think it will cost a typical state to operate mobile crisis. But if we go down to the next one, because of the federal match, including the 85% FMAP that exists in Medicaid for this population, that cost for a state might only be $5 million. But remember, this is all based on how many individuals your teams serve each day. It's going to require your geography. It's going to require analysis. And again, that's what we'll do in subsequent weeks. But you do have a structure in place to start thinking about what does this cost and how many people are we going to serve with this sort of resource. And I think the only other thing I circled there was the parity opportunity. Of course, Medicare commercial, again, they don't typically pay for the mobile response in these 24-hour, 23-hour receiving chairs. So therefore, what's happening is your state budget is picking up on what you see there, a significant cost, millions of dollars that could be paid if we can get parity in place for those services.
Should be paid, Paul, should be.
It should be. And as we circle the numbers there, we are talking about millions of dollars in an opportunity.
Yeah, terrific, Paul. Thanks for this work and continuing to improve on the simulation components of this. Expect more functionality out of this over the course of time. And Paul, you're going to drill down on some specific examples and show folks how to use this over coming weeks. So let's go to the next slide, Karen. Thanks, Paul.
Sure.
Whitney Bunts, thank you so much for joining us. And we've teed up your report previously, but so thrilled to have you today to go into some depth. And I want to get straight to it. So Whitney, tell us about youth mobile response. and how this is a real investment, not only in decriminalizing mental health, but in the language you used of healing Black and Brown communities through this engagement, I thought was really powerful. Whitney.
Yes, hi everyone. Thank you for having me on, David. I really appreciate the time. So as David mentioned, I wrote this report, Youth Mobile Response and Investment to Decriminalize Mental Health, and it was released in early April. And since then, we have been on a roadshow just trying to push out the language and to really get people on board with this idea of decriminalizing mental health. And so, Karen, you can go to the next slide. And so what we did in this report is we really laid out, and I think a number of times we have had a number of people come on talking about the relationship between law enforcement and mental health and how they have been the sole responders of mental health crises and as far as the criminal justice system. But in my report, we took it a step further and we talked about even the mental health system and how they have also been complicit in the criminalization of mental health crises, particularly in Black and Brown neighborhoods. And we talk about the history that Black and Brown people have with mental health conditions, as well as how they have access to those services. And right now, when we look at that, we all know, we've heard this before, that people with mental illness is 16 times more likely to be shot. But for young people, 2 million young people are arrested annually, and 60 to 75% of them have at least one mental health. And when you look a little further into the data, you know that majority of those people are Black and Brown people that are being incarcerated for their mental health conditions. We also know that Black and Brown people that live in low-income neighborhoods also don't have access to mental health supports in schools. They don't have access to insurance that will cover mental health supports. And so we really wanted to really figure out why that is and how we can create an alternative that will allow them access, but also remove police from and interacting with these young people, and to dismantle the school to prison pipeline, but also dismantle law enforcement engagement and mental health crises altogether. Next slide. So we really started off thinking about what it means to be a mobile crisis team. And through this report, we interviewed 3 different states and cahoots. And we chose these states on no particular, for no particular reason, besides they have very robust mobile response teams that deal with young people. So we interviewed Oklahoma, Connecticut, as well as cahoots. And cahoots, unlike Oklahoma and Connecticut, their mobile response team is universal to the population that they serve, but they do serve 10% of the youth, and they have recently moved into high schools once a week to serve as a conduit for mental health services. But Connecticut and Oklahoma, on the other hand, serve young people up to the age of 21 in some areas for Connecticut, but 18 regularly, and then up to the age of 25 in Oklahoma. And their mobile response is a statewide system, and they have been using it, and both of them have recently revamped their services. And one thing that I got from the conversation was that from them was this idea of not using mobile crisis as a language, but also but using mobile response because it's more client-centered and more inclusive. And so throughout the paper and the report, we try to emphasize the language of using mobile response because it is more inclusive and it allows the client to define the crisis for themselves, which will really get away from this idea of using police as a response model. Next slide. So with them, we talked about, in my original slide, but in lieu of time, I wanted to just really focus on the state challenges because I think that really emphasizes some of the things that we have seen. And so we saw that they talked about not having staff capacity. And so we really emphasized like peer support specialists in this report because to build capacity, but also knowing that peer support specialists have a knowledge and a level of professionalism that cannot be given to you through education. And we think that they are necessary to really effectively drive home mobile response and the safety of it. And then talking about building external partnerships and in the community and not being able to do that with schools, law enforcement, hospitals, and state agencies. And then they talked about a lot about the stigma. And I think that goes hand in hand with about what's happening in Black and Brown communities about associating mental health conditions with criminality and criminalizing Black and Brown youth for having crises or doing normal behaviors. And so we wanted to really emphasize that, like, one, we have to break down the stigma and educate people around what mental health conditions look like and the symptoms, but also understanding that, like, it varies and, you know, the right service providers will understand that. And so this helps. And then we talked specifically to Oklahoma about collecting data and understanding that sometimes you're unable to collect data at the beginning of a call because, you know, you're handling a crisis and you don't want to, like, avert from asking a young person about what's happening with them and to, like, actually help them. And so oftentimes they lose that data because they were so concerned about the crises during the interaction that they forgot to ask the questions that they needed to really get the outcomes. So next slide. And from that conversation, we basically came up with 6 principles. And one of the first one that we have on our thing is law enforcement is not the appropriate response for individuals and communities in crisis. So we do not believe in co-responder models. We believe that law enforcement is not equipped and not trained, not equipped, not the right people to interact or to engage with someone with mental health condition, especially young people and young people of color. As we know that young Black and Brown people already have a strained and non-trusting relationship with law enforcement already because of their role in society and what their role has always been. So we believe that co-responder models are not a thing for us. We don't believe that they should happen. We believe that mental health mobile crisis teams with just mental health professional and peer support specialists are well equipped to handle a crisis in those communities. And so one thing that we learned through that is accessibility. Both Oklahoma and Connecticut already have these lines of crisis to get access to crises through different modes other than 911 numbers. Connecticut used 211 specifically. And it's interesting because Oklahoma, before 988 was passed, was already using their suicide hotline, national state hotline. And they also recommended, one of the federal recommendations that they made during our interview with them was to get a national hotline, which then the 988 number passed. So using 988 as a way to access will lessen the barrier for Black and Brown communities to use these lines, because right now we know that a lot of people are scared to call for mobile mental health crises in Black and Brown communities, especially for young people, because the first line of defense is law enforcement. So we know that 988 will be very helpful for these communities and will make it more accessible. And then another thing that we highlight is training is an essential part of mobile crisis response to reduce harm, for harm reduction and positive outcomes. And then we emphasize again the need for peer support specialists and to ensuring that they are cared for and that they are a part of the mobile response team. We also emphasize Medicaid as an essential part. Through our research, we found that a lot of youth mobile response services are using state allocation dollars. Oklahoma is unique because they are one of the only few states that we've seen that use 40% Medicaid funding, and the other 60% comes from state allocation. But all of their providers are Medicaid reimbursable, and they are free for their clients. And then the last one is mobile response is just one component to ensure safe communities. So we know that, like, right now that Black and a lot of poor and low income communities are suffering from more things than just mental health crises. They are also suffering from quality education, no employment, as well as food deserts and lack of housing. And a lot of the states that we talked about homelessness and a lot of people experiencing homelessness. So what does that look like to start thinking about affordable housing? And so a continuum of services and not just mobile response cannot be the panacea to end the crisis that we are seeing in this nation now. Next slide, please. And so, as I mentioned, we really talk about Medicaid funding and ways that states could go about getting Medicaid funding through waivers. Some of the waivers that we've seen people use are the 1115 demonstration waivers, the 1915B freedom of choice waivers, the 1915C home and community-based services, and then people doing legislative change. And that is something Oklahoma did, where they now have billing codes as well as some other stuff for Medicaid reimbursement. Next slide. And then we just finished the report by talking about some federal opportunities. So of course, 988 was already passed, the National Suicide Hotline Designation Act. And so we really just talk about the implementation and how that can serve as a way to create access for young people across the country to get help to get access to crisis services as well as mobile response. We also talk about the CAHOOTS Act, which was actually part of it was put into the American Rescue Plan with an 85% federal match rate, but the CAHOOTS Act as is has a 95% federal match rate for Medicaid. And so we're just hoping to get that passed so that the match rate can be increased. And then the last one, we know that Samson's on the call, and we wrote this paper in response to our last administration, and we know that they are now have a lot of focus and are prioritizing 988. But the one thing, and I changed the slides before, but ran out of time. But one thing that we are asking is just like prioritizing non-co-responder models and really emphasizing that and like really highlighting best practice models for states across the country and providing technical assistance for states that are providing non-co-responder models. Because this, like David mentioned, this is a really good way to start healing Black and Brown communities by building trust and to get law enforcement out of mental health crises. And so the last thing I'll end with, we just recently wrote a sign-on letter to the Department of Health and Human Services asking for guidance on police-free mental health. And my co-worker and colleague, Isha Wersinga, will drop that in the chat. If you all are on board and really agree with this model of police-free mental health, please sign on to that sign-on letter so that we can show Department of Health and Human Services that we believe that we all believe that police should not be involved in mental health crisis services. And next slide is just my contact information if anybody wants to reach out. And if you have any questions, please.
Whitney, thank you so much for your leadership and your work in this area. And in addition to just all the great work thinking about a race and equity lens to our crisis care and the promise of 988 extended out through what happens when you call. In addition to that, you've also brought some great attention to some states that we've not spent enough time on in these meetings, Oklahoma and Connecticut in particular. And if we can go to the next slide, Karen. Whitney, you did recommend Tim Marshall. Tim, are you with us from Connecticut to make some brief comments following Whitney's presentation? Let's see if Tim is able to join us. I'm not hearing Tim. John Draper, are you with us to make any reflections or comments? And John, your background is started in mobile crisis before getting into the call line world. John, reflections or comments?
David, I'm tuning into my video here. Sorry for that. Takes a little while to get in. I have to say that there's when I first got into crisis center work in 1996, it was coming from a mobile crisis team, David. And my ambition at that time was I can't wait to be a part of a service that's going to kind of spread the gospel of mobile crisis work, so to speak. And the idea was essentially to have this 24/7 crisis line that could dispatch mobile crisis teams. And I had the privilege of going into homes throughout multiracial neighborhoods, being with families and individuals who are suffering, and seeing the value of this incredible service and wondering, why is it that people don't know about it? So now we have a chance to actually get people to learn about this important service. That was 1996.
Yeah.
Now we are, what, 25 years later, and there's still many who haven't heard about it. They're only now hearing about it. So my hope is that this gospel will come to fruition, and 988 is an opportunity for mobile crisis services to become ubiquitous. But David, you know, and I know, and we all should recognize it's going to take years for this to happen. While we all very much can't wait for it to happen, and we need to do whatever we can from an advocacy standpoint and fundraising standpoint to make it a reality, it is going to take some time. So when 988 launches officially in July of 2022, the only thing we're really sure is going to be happening is all calls are going to be going to Lifeline. But dispatch for mobile crisis teams will not be a reality everywhere. And we need to continue fighting to make that a reality that we can all count on in the near future.
John, talk just for a moment, if you would. So Brian Sims referenced this critical need for connection in times of crisis. So mobile is going to individuals who have those higher level needs, who need that face-to-face engagement. Talk about the clinical impact of a peer and a social worker or a clinician sitting down with someone in their home.
Well, you know, one of the things that was really kind of mind-blowing to me is that, you know, our system has really been set up, and this is, you know, back in 1988, David, I was coming from working in hospitals, outpatient clinics. That's what I thought the world of mental health was. I had no idea that actually there are house calls that are being made. That seemed preposterous. And when I first went out, it seemed revelatory. Because as I sat down with families and individuals who are suffering, I thought, you know what? This is the way it should happen. This is the way mental health care should be happening. It should be happening not at my convenience, but at the convenience and in the environment of the individual who's suffering. I had the ability to talk with the people that cared about this individual, who sometimes could make it worse or better for them. I could see how they were taking care of themselves in an environment that they were in control of. And so my ability to make connection with them was based on their feeling of safety. They felt safe in their own home, as opposed to coming into my home at an office or coming into my emergency department. So the fact that they felt at home in their home allowed me to learn more about them within an hour than it might have taken months to learn in a setting. So that connection in the place where they are comfortable is the most critical thing about mobile crisis services.
Love that, John. Love that. And Richard McKeon. So obviously our new SAMHSA Assistant Secretary, Miriam Delphine Rittman, is the commissioner in Connecticut. So great hearing about the Connecticut Mobile Crisis for Youth. Richard, any reflections or comments? Again, like John, your background is in the right in the core of crisis care.
Yeah, thank you, David. And you're absolutely right about our new Assistant Secretary, and all of the folks I know in Connecticut tell me that she's been a powerful advocate for both suicide prevention and crisis services. And they have a wonderful youth mobile team and adult mobile team set up in Connecticut, which I think is instructive in many ways. In Connecticut, the point of access for mobile crisis outreach is to call the Connecticut 211 Lifeline Center. And so all requests for mobile outreach go through that center, who they then coordinate rapidly with 6 mobile teams around the state. And the state of Connecticut provides them with $1 million to provide that service, to do ongoing data reporting, quality improvement. They also know when 911 calls come from schools, and follow up to make sure that mobile outreach to find out whether 988 could have, 211 in that case could have been called instead,
Right.
resulting in something other than a police being sent. And again, I think that, there was this horrible story about a young Black child being pepper sprayed in Rochester, New York. I think that what we're aiming for with an equity lens is, rather than calling 911, the mother was concerned about her child being suicidal and was also apparently making some threats of violence, that rather than calling 911, she would call 988. And then if it was not able to be resolved over the phone, that a 2-person mobile team could have been sent without the police, one to talk to the mom, one to talk to the child, potentially with an iPad to consult with a psychiatrist. The chances that that child would never have needed to be forced into a squad car to get to the emergency room, I think that's the kind of system we're aiming for.
Awesome, Richard. And look, we've talked about this promise of 988. So John's right. The pragmatic where we're starting is we don't have enough of this service, but obviously this is urgent for us to continue to build this capacity. So thank you, Whitney, and all of our presenters today. Karen, let's just end with the next slide, the roadmap for future presentations. And Josh Cantwell, terrific. I think, Brian, you were the one who connected us with this CCBHC innovation with technology. We'll get Josh on the schedule. And also be on the lookout for our Moving America's Soul on Suicide series. We're going to drop today a new video, Fighting While Wounded, about the story of Tanja Miles, who's been a regular contributor on this 988 Crisis Jam. Thanks for joining us and hope to see you next week. Take care.